So today we are going to discuss the INICET May 2025 Pharmacology Recall, and I am Dr. Arvinth, your Pharmacology faculty. So in this INICET May 2025, they have totally asked 6 questions in pharmacology. So the questions looks mild to moderate difficulty. So we will discuss one by one. The first question is, carbamazepine and erythromycin was given to a patient and he presented with ataxia and dizziness. Which of the following is the reason for the symptoms? Option A, toxicity of erythromycin, and option B, toxicity of carbamazepine. Option C, erythromycin inhibits the metabolism of carbamazepine and erythromycin induces the metabolism of carbamazepine. So the right answer is erythromycin inhibits the metabolism of carbamazepine. So carbamazepine is one of the most commonly used anti-epileptic agent in children for generalized tonic-clonic seizures and also for the partial seizures. So it is metabolized by the enzyme cytochrome P450 in the liver. So you all know erythromycin is also one of the most frequently used macrolide antibiotic, and as an alternative to the penicillin, especially in children who are allergic to penicillin and atypical pneumonia. And pharmacokinetically, this erythromycin decreases the metabolism of the carbamazepine by inhibiting the cytochrome P450 enzymes, so especially the isoform is cytochrome P3A4. And the increased carbamazepine levels can lead to toxicity, which manifests as drowsiness, dizziness, confusion, and other neurological symptoms. Since erythromycin is known to be a potent enzyme inhibitor of cytochrome P3A4, so inhibition reduces the metabolism of the carbamazepine, leading to this CNS manifestations. And these are the examples for the enzyme inducers and for the enzyme inhibitors. So we should never combine two group of drugs in these classes. So among the enzyme inducers, smoking, carbamazepine, as we saw, and rifampicin, which is an anti-tubercular drug, it also induces the enzymes of the drug that is being taken simultaneously. And chronic alcohol, phenytoin, and we also have griseofulvin, which is an antifungal drug, and phenobarbital, and St. John's wort. St. John's wort, it is an alkaloid derivative used for chronic depression, but because of its potent enzyme inducing property, it's not being used commonly nowadays. And among the enzyme inhibitors, we have clarithromycin, amiodarone, cimetidine. So clarithromycin is again a macrolide. Amiodarone, which is an antiarrhythmic drug, cimetidine among the H2 receptor blockers used for peptic ulcer. Cimetidine alone has a known potent activity to inhibit the enzyme, and azole antifungals, such as most commonly ketoconazole. It is also a potent enzyme inhibitor, and we have alcohol among the binge. Among the chronic alcoholic, they have enzyme inducing property, and the binge eaters, they have enzyme inhibiting property. And anti-amoebic, more prone is metronidazole, and we also have omeprazole among the proton pump inhibitor category, and verapamil among the calcium channel blockers, and isoniazid. Rifampicin is known to induce enzyme, and isoniazid is known to inhibit the enzyme, and we have our erythromycin. So since carbamazepine, which is known to be an inducer, and erythromycin, which is going to be inhibitor, so this erythromycin inhibits the carbamazepine, leading to carbamazepine toxicity. Moving on to next question. A patient was administered imipramine, and was also given diphenhydramine. What can be expected in this patient? Diphenhydramine inhibits the action of imipramine. Imipramine reduces diphenhydramine elimination. Both has antimuscarinic actions, and imipramine also works by increasing the level of diphenhydramine. So the right answer is both has antimuscarinic action. So imipramine and diphenhydramine has antimuscarinic action. So imipramine is a tricyclic antidepressant. So other than inhibiting the serotonin receptor and the noradrenaline receptor and some amount of dopamine receptor, imipramine also inhibits the muscarinic receptor, thereby producing an antimuscarinic, that is anticholinergic action. And diphenhydramine, it is an H1 receptor blocker, which is found to be highly sedative also. This additionally blocks the muscarinic receptor, thereby producing antimuscarinic. So all these effects will be atropine-like actions. So on administering together, they may increase the side effects such as drowsiness, blurred vision, dry mouth, heat intolerance, flushing, decreased sweating, difficulty in urinating, abdominal cramping, constipation, irregular heartbeat, confusion, and the memory problem. So we should not administer imipramine along with the diphenhydramine because of this anti-muscarinic action. Moving on to the third question. The septic shock traps who remains hypotensive despite adequate fluid resuscitation. So option A, we have to give a noradrenaline bolus. Option B, adrenaline infusion. Option C, dopamine infusion. And option D is hydrocortisone 200 milligram. So the answer is noradrenaline bolus. So if you look at the question, the septic shock traps who remains hypotensive despite adequate fluid resuscitation. So this indicates that we have to give a vasopressor. So among the vasopressors or the catecholamines used, noradrenaline bolus remains the vasopressor of choice in these type of scenarios. So if the hypotension persists despite adequate fluid resuscitation, we have to use the catecholamines to ensure adequate perfusion of vital organs and to maintain the mean arterial pressure above 65 millimeter of mercury. So the majority of the guidelines, they recommend noradrenaline bolus as a vasopressor of choice. So answer is noradrenaline bolus. Moving on to the fourth question. Mechanism of action of the bempedoic acid involves by inhibiting. So it is a direct question. So the enzymes involved, option A, dicarboxylic acid, option B, ATP citrate lyase, option C, HMG-CoA reductase, and option D is squalene synthase. So it is a direct question. So bempedoic acid acts by inhibiting ATP citrate lyase. So this bempedoic acid lowers the LDL cholesterol by inhibiting an enzyme called ATP citrate lyase, which is involved in the cholesterol biosynthesis in the liver. And it is also a pro-drug, meaning it requires an activation by an enzyme that is a very long chain acyl-CoA synthase 1, which is called as ACS VL1, which is found primarily in the liver. And once activated, it inhibits this ACLY, reducing the cholesterol production and increasing the LDL expression for a better clearance of LDL cholesterol from the blood. So the bempedoic acid is also a drug used for the dyslipidemia. And if you look at the other options, HMG-CoA reductase. So this enzyme is inhibited by the drug statins, which are the commonly used drug for the dyslipidemia. So this is also one easy question. Moving on to the fifth question. Which of the following is used for the clinical cure of malaria? It's also one of the repeatedly asked question. Option A is primaquine, option B is chloroquine, option B is cartesinate, and option D is sulfadoxine pyrimethamine. So if you look at the question very carefully, they have asked clinical cure of malaria. So the answer is chloroquine. So all the majority of the references, they recommend oral chloroquine for the clinical cure of malaria, which remains the first drug of choice. So look at the dose, chloroquine 600 milligram base at a start dose. So for a child, it is 10 milligram per kg, followed by 600 milligram base on the second day. That is after 24 hours, it is followed by 300 milligram base at the third day. That is at a child dose of 5 milligram per kg. So this is a therapeutic classification. So for the causal prophylactic drugs, the commonly used are 3 Ps. You can remember. One is pyrimethamine, another one is primaquine, another one is proguanil. So they act by killing the pre-erythrocytic forms of the parasite. And for the clinical curative, also called as blood schizonticytes, chloroquine remains the first line of choice. And we have amodiaquine, quinine, mefloquine, pyrimethamine, lumefantrine, artemisinin, and atovaquone. So the drug of choice for the clinical cure of malaria is chloroquine. And remember, the drug of choice for the radical cure of malaria, that is for eradication of Plasmodium organisms or for the species, we use primaquine basically. So the last question is, which of the following statement is not true regarding benzodiazepines and the barbiturates? Option A is they both act on GABA A receptors, and with alcohol it causes CNS depression. And flumazenil can be used in severe withdrawal symptoms, and both are used as anti-epileptic. So here you have to find the statement which is not true. So the answer is flumazenil can be used in severe withdrawal symptoms. So flumazenil generally they does not reverse the sedation due to the barbiturates, and the primary FDA approved clinical use of the flumazenil is include the reversal agents for the benzodiazepine overdose and for the postoperative sedation from the benzodiazepine anesthetic. So all these diazepam, lorazepam is also found to be helpful for a spinal anesthetic or an epidural anesthetic. And there is no specific antidote for the barbiturates. And in case of any barbiturate toxicity, alkaline diuresis with the soda bicarb, it's the treatment of choice. And the barbiturates are also weakly acidic drugs, and in alkaline urine, they exist in ionized form. Hence, they are not reabsorbed. So they pass through the renal tubules so that they get easily excreted from the urine. These are the 6 questions asked. Thank you.